I was tasked to give a lecture comparing local regional therapies and in combination therapies over the last 10 years. So instead of doing, 100 clinical trials in 10 minutes, I just selected a few representative trials. There's my disclosures. Here's a schematic representation of all the possible, where's the laser port on this? Oh, there we go. All the possible combination of therapies or individual therapies that you guys have seen today. You had ablation therapies, intraarterial therapies, radioembolization, scheduling of the local ablative techniques with the systemic, including the TKIs and the checkpoint inhibitors, and then following them up with the biomarkers. So we're going to go through there today. First, we're going to look at combination of or conventional TACE versus DEB TACE, and then DEB TACE versus bland embolization. And then we'll look at Y90 in a couple different settings, glass Y90 in a couple different settings. Then we'll look at TACE plus sorafenib and Y90 plus sorafenib. And then we'll briefly look at the very similar study that Kevin already talked about, ablation plus TACE. All right. First we'll go here. And in these two studies, in the Precision 5 study done in 2010, it was an international multi-center prospective randomized study with 212 patients, showed essentially DEB TACE versus conventional TACE. There is no difference in overall survival. However, DEB TACE was associated with improved tolerability and reduction in serious liver toxicity and reduction in doxorubicin-related side effects, in particular alopecia, hair loss. And in the 2016 Karen Brown MSKCC trial of bland embolization or transarterial embolization without drugs and DEB TACE, the drug-eluting bead with doxorubicin and TACE, showed no significant change in overall survival between the two, with overall survival of about 21 months, which is, again, it's about the wall that we've been hitting up against for a while. So the take-home point is when you're comparing conventional TACE, DEB TACE, and DEB TACE and transarterial, just bland embolization, there's no survival differences, but it is a very heterogeneous BCLC population. Some subgroups will benefit from one technique than the other, and quality of life and post-op embolization side effects may direct your care. And then Y90 in next, we're going to discuss Y90 in survival and glass Y90 in portal vein thrombus. This is a study from Hillegard, a European study, 2002, longitudinal Y90 in intermediate and advanced stage patients with portal vein, some of which had portal vein thrombus. The mean overall survival was 16 months, which comparing the patient populations to the SHARP trial, the time to tumor progression and survival was comparable to the SHARP trial. And this study did suggest that combining sorafenib with Y90 may be of benefit. Next study is the United States version of the study. It's the Northwestern study, where, again, 291 patients. Child-Pugh A patients with or without portal vein thrombus benefited the most. And in particular, if the portal vein thrombus was just in the branch, the survival was about 16.6 months versus the main portal vein, which is about 7 months. So there's a delineating factor there. Child-Pugh B with portal vein thrombus had very poor outcomes. Another radioembolization study that looked not only at how the radioembolization improves survival, but also looked at the effects on the liver function. And I have a lot of stuff underlined here, but the summary on that for this study showed essentially that as tumor progressed, the liver function deteriorated in using Y90 in these settings, and that moving the stage migration from local regional therapy to systemic therapy earlier may be of benefit, particularly in trials. Because if you wait for the tumor to progress, then they will probably also, their liver function will deteriorate from a child Pu A to a child Pu B. So earlier stage migration from left to right across the BCLC criteria is suggested. The final GLASS Y90 study in 2013, a single-center prospective phase 2 trial with only 52 patients, but pretty intermediate and advanced disease. Again, emphasizes that about 20% of these patients cannot be fully treated with Y90 because of shunting. And child Pu A patients with lobar or segmental portal vein thrombus has an overall survival of about 17 months, whereas the main, if it does extend to the main portal vein, it's significantly less, at about 8 months. So in summary, Y90 for survival and in portal vein thrombus. The data that we just reviewed was for GLASS Y90. Y90 is safe and well tolerated. Overall survival is about 17 months for when there's segmental or lobar portal vein thrombus. And the data does suggest starting systemic therapy earlier prior to imaging progression may improve survival. Looking at, now we're going to compare Y90 to conventional TACE. So this was out of the Northwestern group, the premier trial in 2016. Single center phase 2 prospective randomized study comparing chemoembolization versus radioembolization. There's 179 patients, and they found that the overall survival was equivalent. Y90 had significantly longer time to tumor progression, and Y90 showed better quality of life. So, again, just a reminder to emphasize the fact that BCLC is intermediate and advanced is still a very heterogeneous population. And the take-home point from that study again was Y90 has a better quality of life compared to conventional TACE in this diverse population, and Y90 has significantly better time to tumor progression. So if you were going to use it for bridging to liver transplant, may be suggested. And then, so now we're going to move on to compare adding a systemic to TACE. So we're going to go through 3 trials that combined DEB-TACE and sorafenib. The post-TACE in 2011 trial was a phase 3 prospective randomized controlled trial with 458 patients. And how they did this trial was essentially they performed TACE until the patients had a 25% response to the TACE, and then from that point, from the imaging follow-up, then they would start sorafenib. And what they found is whether they gave them sorafenib or a placebo, the time to tumor progression was not significantly different. And you can see here the survivals of 5.4 versus 3.7 months. But the confounder is that it may have been the delay in sorafenib that caused this effect. So we move on to the SPACE trial, which was continuous sorafenib. So they'd start sorafenib at randomization here, and then the patient would get scheduled TACEs throughout the course. And again, the study did show no significant difference in time to tumor progression, but the subgroup analysis did show longer sorafenib treatment duration was associated with improved time to tumor progression. However, there was some degradation in people's liver function, most likely because of the scheduled TACEs. So thus the TACE-2 trial in 2017, which again used continuous sorafenib. So they started sorafenib at randomization, but they did essentially TACE on demand. Unfortunately for this trial, again, it was a negative trial. There's no significant differences in time to tumor progression. And in the study, the quality of life scales were about similar. So from these 3 negative trials using TACE and sorafenib versus placebo, the combination is safe. If you're going to use TACE and sorafenib, a demand TACE is recommended, and the longer the patient is on sorafenib with concomitant TACE, possibly the better time to tumor progression. So now we'll quickly discuss Y90 versus TACE. So this is now, we're briefly going to discuss resin Y90. So this is the SARA trial from 2017. It's 467 patients from a Western population. And in the end, this study did fail to meet the primary endpoint from an intent to treat standpoint, which again, 30% of the patients with intent to treat may actually not get the Y90 because of shunting. So it showed the median survival for about 8 months for Y90, about 9.9 months for sorafenib. And since this was a superior detriment study, it just says that Y90 is not superior. However, the quality of life with Y90 was significantly better than with sorafenib. The Survanib trial is the Asian Pacific version of the SARA trial, and it showed a very similar outcome. Again, intent to treat population. Survival was about 8.8 months with Y90, 10 months with sorafenib. However, if you looked at the treated population, the Y90 survival was 11.3 months and sorafenib was 10.4 months. But again, there was no statistical significant difference between the two. So take point home, neither one showed superiority or detriment. Sorafenib was slightly favored in the intent to treat population. Y90 was favored in the treated population. Y90 did have a better quality of life data. And if you start sorafenib and Y90, it's safe in child Pu-A patients with segmental lobar thrombus or tumor. So now if we combine Y90 and sorafenib, this is the ceramic trial. The results aren't, I don't think, published yet, but essentially there was no statistically significant improvement if they got randomized and they had Sirtex or resin Y90s, sorafenib versus sorafenib alone, except in the subpopulation or the subgroup showed a benefit of if you're less than 65, non-alcoholic, no cirrhosis, there may be a benefit of adding Y90 to the treatment. So then they talk about the liver dysfunction that can result in patients that are going to live a long time after a Y90. The STOP HCC trial, the results are still pending. That's with the glass Y90. It's very similar to the ceramic trial, except with the glass version of Y90. So now let's talk about combining ablative therapies. And in this case, the study we're going to talks about ablative, but that's percutaneous ablation, and they're also calling ablative therapies as intraarterial therapies with a checkpoint inhibitor. So this is the same article that Kevin discussed. It's tremol in combination with ablation in patients with advanced HCC. And these patients, they all had multiple therapies, multiple TACEs, failed sorafenib, and had, so they were pretty beat up tumors. And it was the first study combining immunocheckpoint inhibitor with transarterial chemoembolization. So again, in this study, ablation means percutaneous ablation or transarterial embolization. And the idea with this study is that they were going to do a subtotal ablation in advanced disease and with an underlying immunostimulation medication therapy. So again, they were not going to treat the whole tumor. So the plan was you come in, you embolize or thermally ablate the tumor with tremol on board, and see if the immunocheckpoint inhibitor improves, time to tumor progression and survival. A good number of the patients were biopsied, and all the biopsies did show immunocell infiltration within the tumor, which is not normal for HCC, and the trend was more infiltration after ablation. So here's just an example patient. Again, patient was, this is the taste area of the liver. This is the baseline tumor. 8 weeks later, you see the baseline tumor shrinking, and then this is the tumor that they're actually measuring for a response on. So this was never touched by ablation, and 6 months later, it's getting smaller, and then 14 months later, it's getting smaller. So again, they did this with the objective tumor response outside the ablated area. And this is the swimming plot that Kevin showed, which showed encouraging clinical activity as seen with objective durable responses in a subset of this population. So the take-home message from this study was the combination therapy demonstrated intriguing clinical activity. However, relative contributions from the ablation versus the checkpoint inhibitor therapy still require investigation. So again, the study didn't say how much the ablation contributed, just that the combination does seem to increase the number of patients or it's safe and effective to do in combination together. So these are the current local regional therapy and immunocheckpoint inhibitor or immunomodulator drugs that are open right now, trials that are open right now. We'll go over a couple of them just real briefly. This is a phase 1 trial across the United States using Debtase and nivolumab, centered at Memorial Sloan Kettering. There's another study out of Northwestern combining glass Y90 and nivolumab in in late intermediate to advanced disease patients. Again, nivolumab with just percutaneous ablation, recruiting 530 patients in again across the United States. Ablation with nivolumab again in HCC and all biliary tract cancers. Resin Y90 and Pembro in Chapel Hill combination. So the idea of doing these combination therapies is out there. And this is just it's another combination therapy, but instead of using a transarterial embolization, they use another embolization agent, which I always have trouble pronouncing, girapamazine. It's a lead compound, a new class of bioreductive anti-cancer agents, and essentially it causes necrosis and low oxygen levels. And they are finding some positive responses when combining it with immunotherapy. So at the end of that article, there's a quote that essentially is, I think, what everyone's here for today. Unraveling this complex threaded knot will require true team science, interdisciplinary partnership, and co-education. Only a combined effort between experts in tumor immunology, hepatology, and interventional oncology will enable defining more optimal therapies for patients with HCC. So enjoy the collaborative effort. Thank you.